MS. So to start with, let me invite Dr. Premlata ma'am, who is the current president of Chennai Menopause Society, to address the gathering and give the welcome address. So Madam is the current president of Chennai Menopause Society and a past president of OXY 2022. And currently she is the consultant head of the department of ONG Dr. Mehta's Multi-Speciality Hospitals, Chennai, and formerly the professor in obstetrics gynecology and director in charge of Institute of Obstetrics and Gynecology, Mehta's Medical College, Chennai. And she is an alumni from Madurai Medical College with a vast experience for around 35 years in teaching undergraduate and postgraduate students. And she's presented papers at national and international conferences. Over to you, ma'am.
Good evening and a very warm welcome to one and all. It gives me great pleasure in inviting you all to this webinar on management of menopause and cancer survivors. I think this topic is of great relevance now with improved cancer survival rate now. We are confronting with the care of so many large women who had undergone chemotherapy, radiotherapy, and then they are suffering with the premature early menopause. And apart from hormonal transition, they have a lot of physical, mental, sexual problems in menopause in cancer survivors. And this topic today, we have faculty and all the topics we have selected in such a way to address all these challenges which these women are confronting and the way to treat. And whenever we treat these women, we have to think about the oncological safety and also give them relief. So this topic is of real importance, and I'm really very happy to welcome our chief guest, Dr. Meeta Singh, who was a past president of IMS, and she has spent a lot of interest in menopause. She is doing a specialist clinic in menopause and osteoporosis in her Tanvir Hospital, where she is the co-director. She was the founder chair, research committee of IMS, and she was the founder patron of Hyderabad Menopause Society. I'm really very happy, madam, you found time to accept our invitation and join us as a chief guest. Thank you, madam. And I welcome Dr. Seema Sharma, our guest of honor from Jaipur. She's elected as the editor-in-chief of Menopause Medlife thing. She was the vice president of IMS 2022, and she was the secretary general of IMS 2019, and she was the chairman IMS examination committee for 3 years from 2016 to 2019. She has keen interest in menopause. I'm really happy, madam, you have joined us. Thank you, madam, for joining us as a guest of honor. I welcome all the faculty members, speakers, and chairpersons and the delegates today who have joined here. I'm sure this session will be of great informative and throwing a lot of light on the challenges addressed by these cancer survivors. Thank you. I welcome one and all. Now we go on to the session. Deepa will take us to the menopause prayer. Kuthuvelakku.
So now we move on to the Tamil Thai Vartha and the lighting of Kuthuvilakku.
Shahidi.
இன்ப
So may I request Dr. Deepa Kankamani, who is currently the Secretary of Chennai Menopause Society, to tell the midlife prayer.
Thank you, Niveen. Next slide, Sagati. We pray to God to give us a grace to accept the midlife physical changes and gently renew our strength, guide our heart, our mind, and our body to navigate the way and our trust in you to lead us safely through. We pray for midlife and mature women who cherish the fond moments of their life and also for those sitting in the doctor's office or who are in bed asking for a healing touch. On this day, may all the midlife and menopausal women have the gift of joy and hope and good health. Thank you God for the promise of hope you hold out to all midlife and menopausal women and inspire us to give this gift of hope to others. Thank you.
Now, thank you, Dr. Deepa. Now, it's my proud privilege to introduce Dr. Meeta Singh to the audience. And she is currently the consultant head of the OBGYN and co-director of Tanveer Hospital, Hyderabad. And her areas of interest includes obstetrics, menopause, postmenopausal osteoporosis, PCOS, and gynae ultrasonography. And she's been the editor, Journal of Midlife Health from the year 2020 to 22, and chair clinical practice guidelines on menopause, chairperson for clinical practice guidelines in postmenopausal osteoporosis, and she was the past president of Indian Menopause Society 2012, and she was the founder chair of research committee of Indian Menopause Society and the founder patron of Hyderabad Menopause Society. And we are very happy to welcome you here, ma'am. Thank you for graciously accepting our invitation. And can you please address the gathering, ma'am?
Yeah, thank you, Dr. Nivedita. Thank you, Dr. Premlata, and the team, Chennai Menopause Society, for inviting me for this very interesting session today. And a very happy new year to all of you. And of course, we also welcome Seema Sharma, the incoming editor, a very important portfolio in the IMS. You know, it speaks a lot and a big responsibility when you take up this. It shows the IMS to the world. So, having said that, I think it's a very interesting topic and very much needed for all of us, and especially at menopause because there are actually so many gray areas even without the comorbidities when you're prescribing hormone therapy. So, even more challenging when you're faced with a situation where we have the cancer survivors. So we have the genital and the non-genital cancer survivors, but we generally don't come across too much of the non-genital cancer survivors because they don't have wouldn't have the time to come to us with the menopausal symptoms because they are most of the time treated by their oncologist, the medical oncologist, and the team. So very rarely they come back and visit us once the diagnosis is done. But I think the category that we see most are the breast cancer survivors. Because they come back with the postmenopausal bleeding or the menopausal symptoms, and and nowadays because you're finding them at a younger age group, you may also have to worry about the POI. And second area where the gynecologist most commonly see are the BRCA positive ones, because we are doing more of the genetic testing and we are faced with situations where we have to understand what to do with them when we are faced when they come up with a positive report. What is the advice you're going to give them, and if at all they undergo the salpingo-oophorectomy, then what is the positioning of the hormone therapy that you're going to give them? So I think there is a lot that's going to come up by the speakers, but I would like to say, it so happened that I read up an article recently. We spoke about the lifestyle management. It was talking about actually the obesity. So, but there were some two interesting snippets out of it, which I would like to share with you, where they said the Fitbit and the apps which everybody wears around the wrist to find out how many steps you're carrying throughout the day. And they studied these people over a period of 4 or 5 years, and I think more than 185,000 people. And what they found was very surprising, that people who did more than 3 to 5,000 steps, the cancer rate was much lesser compared to the people who did not. So that is the power of exercise and anti-inflammation, as we call it now. But that was an observational study. To along with that, so this report also commented on an RCT which was done on a colorectal cases of colorectal after post the treatment once everything is over. So people who opted to go for the exercise program and people who didn't opt to go for the exercise program, so there was a 26% reduction in the colorectal recurrence. It's really huge when you look into the numbers. So that is what the lifestyle, the food, and your physical activity and the exercise will add on, to the value to these cancer survivors, which we should not be forgetting, because they are actually drained out of the chemotherapy, the mental exhaustion, the emotional drainage. But we should be encouraging them, at least if not with the medications, the lifestyle management. So all the very best for this session. Thank you for inviting me.
Thank you, ma'am. So now it's my great pleasure to introduce our guest of honor, Dr. Seema Sharma from Jaipur, from Sankalp Gynec Care. She was the ex-professor and head Department of OBGYN, JNU Medical College, Jaipur, and former professor and unit head in Mahatma Gandhi University of Medical Sciences, Jaipur. She's been the associated editor of JMH and editor of IJOGR and IJOG, and vice president of Indian Menopause Society in the year 2022, and Secretary General of Indian Menopause Society in the year 2019. She's been chairman and IMS examination committee between 2016 to 18 and scientific convener of NARCHI Rajasthan branch 2015 to 17. She has been the vice president of JOGS 2019 and vice president Rajasthan branch of NARCHI 2017 to 19. She's been the invited speaker for national and international congresses, and she has more than 50 scientific publications to her credit. Over to you, ma'am.
Thank you. And Honorable Chief Guest, Nita ma'am, and Dr. Premlata, Dr. Deepa, the organizers of this profound program. And I extend my gratitude and thanks especially to the organizing team and Dr. Hapsi, who called me personally to be a part of this event. And I think you have curated this program to a very timely and meaningful subject, that is management of menopause in cases of cancer survivors. And this session reflects evolving landscape of menopause care, one that demands sensitivity, scientific rigor, and deep understanding of survivorship. Because these are the women who have journeyed through the cancer and they have come out of it strongly. So now it becomes our responsibility that after treatment years, they remain with grace, with comfort, dignity, and evidence-based care. And the design of this program is so beautifully designed. And we'll see, to start with, Dr. Sunita will be taking care of CA breast survivorship. And we know that the survivors of CA breast they have a delicate balance between symptom relief and oncologic safety. And to manage these, we need to have their whole histopathological and receptor status in our mind. So this is an area where we should have the liaising with the oncologic team also. And this is same with the endometrial cancer also. We have to see for receptor positivity, and we have to accordingly design or tailor our therapy, because systemic therapy may be dangerous in these cases. So again, we come to the lifestyle management for these patients. And this is heartening to see that you have included the non-hormonal therapy also in the form of fezolinetant, that is neurokinin 3 antagonist. That is really a frontier nowadays in menopause care, especially in these cases which has come through the cancer management, and now they are suffering from the menopause symptoms. So, and also again, Dr. Rajshree's talk on lifestyle interventions remind us about the management of menopause, which is not only about prescription. It is beyond that. It involves a holistic care, as Meeta ma'am already said, that it has got many other things also, and it has a profound role in itself. So it is about empowerment through nutrition, through movement, through sleep, and emotional resilience. So as we go through this program, we let us symbolize our collective commitment to illuminating the path of midlife health with wisdom, empathy, because empathy has very much a role in the care of these women, and also inclusion of innovation. Let us continue to collaborate, educate, and advocate for every woman navigating through menopause after cancer with courage, clarity, and care. Thank you once again for having me, and I wish Chennai Menopause Society continued success in its mission to elevate menopausal care across India. And also, as Madam has said, that I have to take on the post of editor-in-chief. I invite you also on this platform, because our journal is a very committed to academic rigor and transparent review process. So I invite you, the academicians and clinicians, to join as reviewers and design some robust clinical studies to publish in our journal also, because it's the journal of our own society. Thank you.
Sure. Thank you, ma'am, for your nice words. And next, may I introduce the chairpersons of the session, Dr. Meera Raghavan and Dr. Nandita Thakkar. Dr. Meera Raghavan is a senior consultant urogynecologist and robotic surgeon, and she is a proctor and trainer in Hugo Ras robotic platform. She's a convener of TNFOG certificate course in urogynecology and board certified lifestyle medicine physician and national board specialist committee member and treasurer SOPSI of Tamil Nadu chapter and the core committee faculty of Urogyne Committee of FOXI since 2015, scientific chair AACC RCOG 2025, and she is a national board coordinator and examiner as well as MRCOG trainer and examiner, and she is a director Ascot Apollo Simulation Center coordinator for obstetric skills and winner of 32 gold medals in undergraduate curriculum and best outgoing PG student from PGI Chandigarh. And next we have Dr. Nandita Thakkar, who is the medical director, Nandita Fertility and Research Center, Chennai. She is the academic head and coordinator, Mehta Hospitals, Chennai. She's been the joint secretary of CMS from 2025 to 2027, and her areas of interest include reproductive medicine, high-risk pregnancy, genetics in OBGYN, lifestyle, and gynec disorders. She is passionate in teaching and focused training programs, which include skill training, workshops, and designing teaching modules. And she has presented papers at national and international conferences. I welcome the chairpersons and I request the chairpersons to take on the session further. Dr. Meera and Dr. Nandita.
Yes, I'm here, Doc.
Okay, madam.
Because I'm actually feeling
So,
kind of normal, but when actually fed it into AI told us very.
Nandita, you can call Dr. Sunita.
Okay,
yeah,
so may I call upon the first speaker of the session, Dr. Sunita Samal, who is the consultant obstetrician and gynecologist, laparoscopic and robotic surgeon from Apollo Women's Hospital, Chennai. She has 16 years of experience in undergraduate and postgraduate teaching, and she also is a diploma national board faculty. And she has special interest in minimally invasive gynec surgeries, high risk obstetrics, basic fertility, and medical education. She has around 54 publications to her credit in national and international journals, and she has received the Best Poster Award in AACOG 2015 and 17, and first prize in Foxy Zonal Quiz 2002, and Dr. Anjalakshi Chandrasekhar Award for Best Research Paper in Oxycon 2020. She also has received International Scientist Award on Science and Medicine in 2021. She has organized various CMEs and workshops and presented paper and she was the faculty in various national and international conferences and she is a member of the FOXY, OXY, IAGE, AMSI, and ISUOG. Over to Dr. Sunita.
Yeah, thank you, Dr. Nivedita, for the kind words. And at the outset, I'd like to thank the whole CMS team for this opportunity. Yeah, so I'll just share my screen. So my topic is quite interesting, as Nita Madam told, like most of the, like you were seeing this breast cancer patients, breast cancer survivor you are seeing nowadays more. So we are going to discuss regarding this. This will be the, in this line, I'm going to discuss the topic. So all of you know.
Sunita, you can make it as a slideshow.
Yeah, sorry, madam. Yeah.
Thank you.
So all of you know, like breast cancer is the most common cancer in the female, like worldwide, and affecting almost 1 in 5 women who are mostly premenopausal at the time of diagnosis. And when you give the treatment, this premenopausal women, they enter into the menopause and leading to menopausal symptoms, either due to the chemotherapy or due to the endocrine therapy. And this increased incidence of breast cancer, it is, and the survival, it is mostly due to the early detection and the improvised treatments. So that the most of the women, even if they are at the premenopausal age group or a perimenopausal age group, because of the therapy, they are going to the menopause and having this postmenopausal symptoms. So if we'll see in the early breast cancer treatment, like when they are in on endocrine therapy, almost 90% of the patient, they experience severe vasomotor symptoms. And all this, like it is attributed to the chemotherapy, which is can cause a temporary or permanent ovarian suppression or and the low estrogen levels in premenopausal women, or it can be due to the endocrine therapy, which is used to reduce or the block the estrogen receptor in the breast cancer survival, approx, or like it is among all the ages. So why do breast cancer patients they develop menopausal symptoms? So you will see already I mentioned almost like several studies, or like it is almost 65 to 85% of the women are affected, and it is due to the young woman with the chemotherapy induced ovarian failure, or young woman undergoing oophorectomy due to the genetic mutations, or peri or postmenopausal women who stop HRT on the diagnosis of the breast cancer. Pre and postmenopausal women taking endocrine therapy for up to 10 years, they can develop. And hot flushes are more frequent and severe than in the spontaneous menopause when any breast cancer survivor they develop. And mostly this anti-estrogen therapy, it may exacerbate the symptoms, particularly the vaginal dryness with the severe and which is more severe with the aromatase inhibitors. If you look at the study, so among all the menopausal symptoms, the hot flushes, night sweat, and the vaginal symptoms, the genital symptoms are more prevalent or more it is appeared both in the hormone therapy and hormone and chemotherapy both together. So what is the effect of this chemotherapy and the endocrine therapy? Either tamoxifen or the aromatase inhibitors on the ovarian function. So most of these breast cancer, they express either the estrogen or the progesterone receptor, making it a hormone receptor positive breast cancer, which is most common subtype. And this anti-estrogen endocrine therapies, these are the backbone of the adjuvant treatment whenever there is a HR positive tumors. So most commonly used is the SERM, which is the tamoxifen, and it all of us knows like it acts as a competitive antagonist of the estrogen receptor, and it can be used both in pre and the postmenopausal patients. And it causes a premature menopause when it is used in the young population. And in contrast, when the aromatase inhibitors, they inhibit the peripheral conversion of the androgens to the estrogen, and they are ineffective in the premenopausal people. And unlike they, when they combine with the suppression of the ovarian estrogen production with the chemical or with the surgical ovarian function, and it blocks the estrogen synthesis. And particularly in the premenopausal women, when it is used with the ovarian function suppression, they induce a profound premature menopause symptoms. And this long-term estrogen suppression also, it increases the risk of osteoporosis, which necessitates the bone density monitoring for this kind of woman. So as we know, this endocrine therapies, it is causes profound menopause by blocking the estrogen receptor. So why are these menopausal symptoms why we need to be discussed in the breast cancer patients if they develop menopause? because they may impair the quality of life, which is worse than the cancer treatment for some women. And it may impact the tolerance of the endocrine therapy also. Sometimes like 40% they discontinue because of the hot flushes. And it may add to the common post-cancer problems like such as sleep disturbance, fatigue, generalized weakness, all the symptoms. It may have implications for the prognosis also, and risk of early menopause. It may contribute to the morbidity and the mortality, like the long term there is a more chance of osteoporosis and the development of the cardiovascular diseases. So when there is a menopausal symptom, so what can I do to treat these menopausal symptoms after the breast cancer treatment? So there is no single non-hormonal treatment for all the symptoms like vasomotor symptoms, vaginal, mood, and the bone health. So it need to prioritize and consider the multiple interventions, and most effective are the non-pharmacological and non-hormonal therapies, which is plenty available nowadays. And we need to some tailor interventions to individualize individual simple symptom burden. We cannot have a single treatment for the all kind of the diseases. So how do you manage the vasomotor symptoms? As we know, for a routine postmenopausal woman, there is a hormonal, non-hormonal treatment. Then you give a lifestyle modifications. So similarly, here also the first line of management is always the symptoms include the lifestyle modification. That means the initial thing is the low risk lifestyle, like the vasomotor triggers. You have to avoid all these things, like avoid spicy food, daily taking coffee or tea, alcohol, and dressing layers. That means maintain a cool environment, and that is for the just to avoid the vasomotor trigger. Then coming to the diet and the bone health, so they should routinely supplement with the calcium and the vitamin D, and because it is more happens with the aromatase inhibitors, and also we should advise them to do the weight bearing exercises, which will help them in maintaining the bone health. And physical activity like regular exercise or some walks such as walking, as Neeta madam told, like a minimum in 5,000, that also reduces the cancer risk. And similarly, it's also it helpful in managing the postmenopausal symptoms. And it helps in manage the weight and improve the psychological well-being, not only the physical symptoms, also there will be a psychological, mental well-being also. It have this regular exercise. And coming to this pharmacological non-hormonal therapies, for initial you start with the lifestyle modification, but for moderate to severe symptoms where non-hormonal, there you can add, give the non-hormonal medication, which is the gold standard. Like initials to start with either SSRI or the SNRIs like venlafaxine or escitalopram, which is very effective. But whenever you are using pyroxetine and patient is on tamoxifen, we have to be very careful because it interferes with the drugs metabolism. And another one, oxybutyrine, which is used like overactive bladder medication, but it can reduce the hot flashes almost up to 70% of the cases. And but you have to keep in mind this can cause some dry mouth and the constipation also. So you have to just inform the patient regarding side effect. And other neuromodulators like gabapentin and pregabalin, these are very effective, particularly in the night sweats and the sleep disturbances. And it will see the several studies also that tells like it is safe. This non-hormonal therapies are very safe in the pregnant, in the breast cancer survivor. There is no negative for these people, and this is the gold standard for the initial treatment of the postmenopausal symptoms. And coming to the newer agents, which is now new, Dr. Seema also mentioned regarding these new drugs, which are like neurokinin receptor antagonist, like one is elinajetant, another is fizolinetant. So these are also they are very promising treatment for the breast cancer survivors with who develop vasomotor symptoms while an endocrine therapy, and along with reducing the symptoms of hot flashes, they also significantly improve the sleep quality, and by blocking the signals that trigger the temperature dysregulation. And similarly, the second drug, which is a NK3 receptor antagonist, which is recently approved in 2023 for general symptoms. And details of these drugs, I think Dr. Nitya is going to speak regarding this medication. And the second drug, which is they require a liver function monitoring, and due to rare but serious some warning symptoms in the liver. Okay, so why is the systemic? Why you are talking about the lifestyle modification? Anyway, we give for everybody, even not even a not non-cancer patients also. But whenever the symptoms become very severe, we give them the HRT. means menopausal hormonal therapy. But why it is avoided in a breast cancer survivor? Because there is a, like you will see some meta-analysis, it has found like the systemic HRT significantly increases the risk of breast cancer recurrence, particularly in patients with a hormone receptor positive case disease. And it also, estrogen also can stimulate the proliferation of the breast epithelial cells, acting as an oncogenic factor and further progression of the cancer. And this it can directly also counteract the beneficial effects of endocrine therapy like the tamoxifen and the aromatase inhibitor, but it becomes the contradictory like effects. And there is also increased breast density. So the systemic, it can again uh, create some problem in the mammography for the less like to effect in the new tremors during the process and during the follow-up therapy. And clinical trial evidence is suggests like the habits trial were terminated early due to the unacceptable risk of recurrence of using the systemic HRT. So this HRT after breast cancer, there are the three major trials Habits, which is done in 2004, which included 345 women, then another is Stockholm trial, and the Liberate. Liberate, they have used the Tibolon, and this Habits and Stockholm, that is mostly the regarding the tamoxifen. So if you'll see this graph, like initially the first uses of hormone therapy in the breast cancer in the postmenopausal, it started around 1942. So above this 50 years, they have seen once it is crosses 20 to 30 years, there is a surge of breast cancer risk in in both retrospective and the prospective study they have seen. And from this habit trial, there is a risk ratio of breast cancer is around 3.5. So they found some patients with a node positive and with a 21% in the tamoxifen use, and most of them using continuous combined HRT. And the second trial here also with the tamoxifen use, either you can use 16% node positive, keeping the ratio is around 0.82, and the 73% they found with the estrogen only at the long cycle of adding the progesterone. So these are the two reports of these habits and the Stockholm trial. And the third trial, which was done 2007, and that they use a Tibolon, and Tibolon, though it is very good in overcoming the postmenopausal symptoms, but it is not safe option for the most breast cancer survivor, because prolonged use of Tibolon, that can increase the risk of breast cancer. So if you'll see, this is another the recent guideline from all the societies, and this is a CGF, means it's a combined study of this hormone therapy in the breast cancer. It's a meta-analysis. So in 2019, that means the duration dependent increase in the risk of breast cancer increases with both the same, either alone estrogen or the combined hormonal therapy, and it is higher with the continuous combined menopausal hormonal therapy than the cyclical therapy. And the risk of breast cancer, even it remains elevated after 10 years of the discontinuing the therapy also. And there is no estrogen doses effect on the risk of breast cancer with hormonal therapy. And vaginal estrogen exposure did not increase the risk of breast cancer diagnosis and delay. And only a small number of women with the micronized progesterone are included. So we cannot comment on the whether micronized progesterone is more associated with the breast cancer risk or not. So how do you manage the GSM? So this is a very important, as I told, this breast cancer survivors, they, along with the vasomotor symptom, this is also the very important symptoms what they face in day-to-day life. So how do you manage? Initially, we always do with the non-hormonal moisturizers, which can normally the vaginal pH and reduces the vaginal dryness. And also that helps in the sexual activity, lubricants can be used. And then if it is the symptoms are not it is not come overcome along for with this non-hormonal moisturizers, then you can use the low dose vaginal estrogens, preferably pills or rings, or if it is not available, you can use the cream, may be considered, and even in the ER positive cases, but always it has to be discussed with the oncologist before prescribing this hormonal vaginal low dose estrogen. And it is also unlikely to increase the risk of recurrence. It can be considered in whenever there is a very severe genitourinary symptoms and if the non-hormonal moisturizers fails. That means the first line of treatment in the in the GSM is always the non-hormonal moisturizers. And specifically containing the hyaluronic acid. And this alternative therapy, like the recent therapy, like vaginal laser, like this cosmetic gynecology, now they are utilizing this vaginal laser. It is very effective, but there is not many studies with that, but it is still they are using now with this laser. And another is the DHEA, like which is also like there is not many, but there is a pilot study I'm going to tell regarding that. And then the ospemifene, which is a recent the third, fourth generation SSRI. So it is not contraindicated. So these medicine, these things can be used like if the hormonal and this non-hormonal moisturizer it fails. And this is one pilot study which is used the DHEA, like vaginal DHEA. Here they have seen after this, including this many women. So there is a like symptoms of physical examination regarding the sexuality and the vaginal health has improved significantly, and the serum estrogen level also remain low. So there is a like this, that means it is acceptable treatment in a patient with the breast cancer when the non-hormonal like vaginal things are not useful in managing the symptoms. And the local estrogen surgery, it is most effective and controversy, but it is most effective in a non-cancer patients. But there is a controversy, as I told. So you need to discuss with the oncologist when you start the treatment, in a receptor positive tumors. And often there is a no improvement with the non-hormonal cancers. So we have to discuss with the oncology team, and you can start. And there is no recurrence of disease with the local estrogens, as per the literature evidence. And coming to this integrative and behavioral approaches, so as you know, like there are for a menopausal symptoms along with the lifestyle modification, you also there is acupuncture like therapy, like some data is also so there is a 2 weekly sessions for 10 weeks. It can significantly reduces the hot flush and improve the overall quality for the woman and who has an anti-hormonal medications, and also this cognitive behavioral therapy that also helps a lot, and weight management. Like even losing a 10% of the body weight has been shown to reduce the vasomotor symptoms and improve the long-term breast cancer prognosis. So as like we know, like exercise and the lifestyle modification, it is helpful for us in each and every disease. So like that, this also like acupuncture, and there are some studies which have shown acupuncture is, there is of course there won't be any like risk factor or there is no contraindication to do this. So this is quite safe. And I think Dr. Rajasri is going to tell in detail regarding the lifestyle modification. And coming to the guideline consensus, like this is North American Menopause Society, like hormonal therapy usually in the survivors of the breast cancer is generally not advised. But if the symptoms of it is very severe and non-responsive to the non-hormone options, then we have to discuss with oncologist, and also you have to inform the patient regarding the risk and benefit before starting it. But generally, it is not advised for a postmenopausal symptoms in a breast cancer survivor. So fast line of therapy is always start with the non-hormonal options along with the lifestyle modification. And in like women who are taking anti-estrogenic therapy such as aromatase inhibitor, estrogen therapy based therapies are absolutely contraindicated. And coming to the GSM, again, always you start with the non-hormonal options like local application vaginal creams and the low dose vaginal estrogens. It can be considered if the symptom persists, and sometimes it may be concerned with when the woman is using the aromatase inhibitors. And DHA, I told there is a pilot study, so but we have not, it is not very plentifully studied. And from that pilot study, maybe the persistent and severe symptoms, it can be used. And vaginal laser, that is also now it is coming up. Many cosmetic gynecologists, they are now using this vaginal laser. This is also useful, and whenever it is needed, if the first therapy fails. And nasmifene, it is not approved till now by FDA, and for the women in with the breast cancer. I don't think it is available in India also. And then coming to the like during cancer treatments, as I told, first with the lubricants and the moisturizer. If there is no improvement, you can go for the local estrogen or the laser or the hyaluronic infiltrates along with that. And if there is no improvement, last is you can use the topical testosterone or you can use the DHA. And similarly, after treatment, you can add initially itself with the lubricants and the moisturizer. Asmifene may be added, though it is not FDA approved in the use. Okay, this is the Australian guideline, like menopausal guideline. This is the recent guideline. Same thing for vasomotor symptoms, sleep disturbance, and the vulvovaginal. So everywhere, like this cognitive therapy, yoga, acupuncture, exercise, these are all the first thing of line of therapy in all these cases. And this black cohorts and other thing, they are not much helpful. And this is one study where they have said black cohorts are like it is safe, but it is not much helpful in if there is no contraindication, but it can be used in a postmenopausal symptoms in a breast cancer survivor. And similarly, leading to the other drugs like the SSRI, these drugs are quite safe. And for both vasomotor symptoms and the GSM and menopausal hormonal therapy, as I told, antibolon, both are not advised in the menopausal symptoms with a breast cancer survivor. And all the scientific evidence is the SSRI, SNRI, and the gabapentin, they almost like reduce the symptoms by 40%. The cognitive behavioral therapy and lifestyle alone, they can improve up to 25% of the symptoms. And vaginal estrogen, they also relieve for the genetics around 20%. And the phytoestrogens and others like general measures, they can reduce around 15% of the symptoms. And this hormonal therapy in women at a high risk for breast cancer. So we initially discussed those patients who are already breast cancer treatment on induced menopause because of the hormonal therapy or the chemotherapy. And here, whoever like are high risk for breast cancer, so for them like a systemic HRT as per the current NCCN guidelines. Regarding the systemic use of systemic MST in high risk individuals over the age of 50, and there is therapy associated with the increased risk of breast cancer risk. And similarly, estrogen only therapy also, and who have had a hysterectomy, the estrogen therapy may be considered. And but you have to discuss regarding the combined therapy, different risk profile compared to the combined therapy. And similarly, vaginal estrogens, they are also considered like it is a safe option for the even for the high risk women or the survivors, because it is having a minimum systemic absorption. And when it is not used vaginal estrogen for more than a year and together, that time maybe it is a risk, but otherwise it is quite safe. And similarly, the BRCA mutation carriers also, it may not significantly increase at the those patients who are not unaffected by the BRCA carriers and who have undergone the risk reduction surgery like oophorectomy. And similarly, the family history has no additive impact on the breast cancer risk with HRT use. Although the women with mutations are mostly like increased lifetime risk of breast cancer, HRT use and family history had a independent and a non-interacting risk factor as we saw of breast cancer, as we see in the studied already in the WHI study. And the long-term observational studies also have reported no extra risk for those using HRT with a family history of breast cancer. And HRT following the risk reduction surgery also appear not to increase the risk. And in such women is used like minimal progestogens, ideally either progesterone or the dydrogesterone can be used. Challenges and issues in this menopausal symptoms in a breast cancer survivor. So because we are not able to use the hormone therapy, these patients who are not comfortable or who are not symptoms are not taken after the non-hormonal treatments. And there are also a lot of evidence gaps, like we don't have that much of data showing like in the cancer survivors whether to use which type of medicine. That is also important. And there are some barriers to effective management, like to assess the specialized care and also prohibiting the cost of non-hormonal treatments. And there is also some complex regimens due to some side effect and to reduce the therapy of this benefit. So all this needs to be addressed. So what are the innovative solutions? So there are some novel non-hormonal agent or a selective receptor modulator which provide a selective symptom relief with minimal breast tissue stimulation that can be utilized. These are all newer therapies and app-based this cognitive CBT also symptom trackers, telehealth enhanced symptoms monitoring, and these things can be also taken care. Minimally invasive devices like wearable cooling systems and the intravaginal devices provide non-pharmacologic symptom control, and it can be targeted local therapy. That also can be used or integrated, like there is always multidisciplinary like treatment including the oncologist, gynecologist, and the psychologist for a rehabilitation of all these patients with the postmenopausal symptoms. So coming to the conclusion, this menopausal symptoms in women with breast cancer, they need a significant, they have a negative impact on the quality of the life with both short and long-term consequences. And it is the management is so directed at the relieving these troublesome symptoms, minimizing the risk of cardiovascular disease, osteoporosis, and the breast cancer recurrence. And this MST after breast cancer is not usually recommended, regardless of the hormonal status of the breast tumor, of the tumor. And in a variety of non-hormonal therapies, also like we are using non-hormonal therapies mostly, and the safety of the botanica means phytoestrogen in the breast cancer survivor is unclear. So we cannot tell it is totally safe or it is contraindicated. So managing these menopausal symptoms in breast cancer survivors, it always requires individualized, patient-centered and a multidisciplinary approach. So because this systemic the menopausal hormonal therapy general avoided due to the concerns about the recurrences. So the focus has shifted towards the lifestyle modification and the non-hormonological pharmacological interventions. So always the lifestyle modification is the first and the initial treatment of this menopausal symptoms, whether it is a vasomotor symptom or it is a genitourinary like a GSM, or it is the long-term protection regarding the cardiovascular diseases and the bone health. So thank you so much for the kind listening.
Thank you,
Thank
Dr.
you.
Smita, for this elaborate presentation. May I request the chairperson to give their comments?
I think ma'am has covered the whole topic quite elaborately and given a wonderful overview of the subject. Any questions do you have? Then we'll raise it, or we'll raise it at the end.
Meera has joined now.
Okay.
I'm here, ma'am.
Done. Yeah.
Meera Raghavan here.
Yeah. Meera, you want to introduce Dr. Dana?
Yes, ma'am. Yeah, please. Pleasure.
Thank you, ma'am.
Thank you.
Thank you.
Thank you all for inviting me here. It's a great pleasure and honor to introduce my very efficient partner in working and a great friend and senior, Dr. Dhanalakshmi ma'am. She's professor and senior consultant Department of Obs and Gynae at Srihar Ramchandra in Chennai. She's an excellent teacher dedicated to the cause of education for both undergraduate and postgraduate training. And I've seen her walk the talk for such things, especially with regards to presentations and revision courses. And I've had the great pleasure to work alongside as part of the core committee in Chennai Menopause Society when Madam was treasurer the last term. Looking forward to hear from Madam regarding the C endometrium and C cervix. Thank you, ma'am. Over to you.
Thanks for the lovely introduction.
Thank you, ma'am. Welcome.
Are you able to see my screen? Are you able to see my screen?
Yes, ma'am. Yes, madam.
Yes, ma'am.
Yeah. Now I know like Dr. Sunita would have covered the entire gamut of hormonal and non-hormonal treatment for cancer survivors.
You have to remove that
So,
screen is not fully thing. Before that,
Okay.
one more screen is seen.
okay. Okay, ma'am.
No,
Behind is a PPT.
screen only, ma'am.
It's seen clearly, ma'am.
I'll share it again. I have not shared, right? Is it visible?
No, now it's not visible.
Now it is not visible.
I'll
No,
share
ma'am,
it. I'll
no,
share
no.
it again. I'll share it again. Is it visible now?
Yes, ma'am.
Yes, ma'am.
Now
Yeah.
full screen, madam.
Yeah. Is it full screen now?
Yes.
Yes.
Yes. Is it moving? Yes.
Double click on the slide, ma'am.
Yeah. Where is my screen? Is my screen on?
Or else you can go to the left corner for moving to next slide, ma'am.
Yeah, I know, but my screen is gone. Yeah, I wanted to minimize this. Okay. Are you able to see the screen now?
Yes,
Okay, so I know Dr. Sunita would have covered most of the hormonal and non-hormonal management of cancer survivors with regard to breast CA, and more or less that applies to gynec cancer with pertaining to CA endometrium and CA ovary. We have brought in CA cervix to complete the show. Otherwise, CA cervix as such is not a major contraindication to institution of menopausal hormone therapy or menopause management. So we will talk about each one of them. I just want to bring out the rationale why we should think of a plan for this cancer cervix, or I mean cancer endometrium or a cancer ovary survivors, and how do we assure quality of care for these survivors. And I just chanced upon a nice article in Up to Date, and I'll bring the essence of it to the next few slides. Is it moving?
No, ma'am.
Yeah.
Now you started.
Yeah. Why we
Now
need
it's
it is
it
because
started moving.
there's a lot of improvement in cancer screening. We are able to identify them much earlier. There's an advancement in treatment options are available, and definitely there is an increase in life expectancy following definitive cancer treatment. And as such, we are living longer. We have been bestowed with better life expectancy. And while we are waiting for this cancer survivors to complete their life term, we are also seeing new and recurrent malignancies in them, and they are also experiencing morbidity and mortality from cardiovascular, skeletal, and other diseases. And the physical effects of the disease, or because of the treatment, like peripheral neuropathy and lymphedema, are endured, and psychosocial distress affecting work and social relationship. And why do we need it? Again, this brought a major question to the Institute of Medicine in 2006. They found there is a gap between what is a cancer patient to a cancer survivor. Somewhere we are losing them in between. After the cancer part of the treatment is over, they are left in nobody's land. Neither the cancer surgeon is too busy to take care of them, because he or she has got a lot of other cancer patients to take care of, and the physician or the gynecologist whom the patient comes back is clueless about how to give this after cancer care. And so the recommendation was to, by the IOM, was to give a specific survivorship care plan, so that it will make this transition very smooth, and it will also help the patient manage her health on a self basis. And they live long enough to reach natural age of menopause. For example, a patient who's diagnosed with CA ovary at 35, okay, after the treatment is over, she can live past that the standard menopausal age of 50, and some of them can attain premature ovarian insufficiency due to oncotherapy, and with its own accompanying disturbing vasomotor symptoms, long-term negative cardiovascular and skeletal effects. And these cancer survivors usually seek the help of a endocrinologists, whether they are candidates for HRT. And the WHO results have clearly shown that patients who attain premature menopause or hypogonadism, they have a decreased lifespan, and through both the skeletal and cardiovascular effects. And this negative effect correlates with the length of the hypoestrogenic period. The more number of years they spend after the initial premature menopause, induced premature menopause, and the time they are going to live. This clearly determines how much they are going to be the suffering period. And so menopause management for gynec cancer survivors is one of the major things that is going to be part of your survivorship care plan. And how we are going to achieve it. I know energy balance factors are going to be dealt by Dr. Rajeshri in the next section. She's going to talk of diet, which is the energy that is consumed, physical activity that is where the energy is expended, and adiposity is where you are not able to adequately expend the energy. It's going to be retained as a fat in the inappropriate places. So while you are managing these three, you can have a better quality of life, which can minimize the disease and treatment related side effects for cancer survivors. And the hormone replacement therapy in oncology with respect to women, mainly addresses hot flushes, vaginal dryness, and mood disturbances, all of which have been thoroughly discussed by Sunita Samal, my previous speaker. And most of this hormone that are used are either estrogen or progesterone or androgens. And this we are considering HRT mainly for patients who have a premature menopause, either after chemotherapy or after radiotherapy or a surgical removal of gonadal tissue like in oophorectomy. Okay, and endocrine therapy, what we are using for breast cancer, aims to suppress the hormone signaling to treat the hormone sensitive malignancies. But what we are doing in HRT or menopausal hormone therapy is to restore this hormone balance in survivors experiencing reduced quality of life due to vasomotor symptoms or genitourinary atrophy or osteoporosis. So we use it in a different context, that is restoring the hormonal balance without compromising the cancer outcome in these patients. So all this which are caused by iatrogenic hypogonadism. Now we have to look at this role of MHT from two aspects. One is whether the MHT itself can induce tumors in patients who have no oncologic history in the past, whether the MHT which you are introducing after a cancer treatment has been done, whether it can cause a recurrence and progression in cancer survivors. So there's a clinical dilemma whether you are going to give symptom relief or whether you're going to risk a recurrence or progression of the ongoing disease. So what we need to know is we have to know the side effect profile of HRT in cancer patients, underlying biological mechanisms, recent evidence. So Sunita Madam has already told everything about this underlying biological mechanisms, recent evidence from clinical studies, implications for personalized survivorship care. So one shoe will not fit all. So we'll have to tailor the treatment based on the patient profile. And not only we have to talk in terms of gynec cancer survivors, it also applies, the same principle will apply to survivors due to hematological malignancies, sarcomas, and GI cancers who develop hypogonadism either because of gonadotoxic chemotherapy or because they have undergone pelvic radiation. And she also beautifully brought out this non-hormonal management of hormonal deficits in the form of SSRIs, SNRIs, gabapentin, vaginal moisturizers, lifestyle intervention. And here there's a role for shared decision making. Now coming to general management, general consideration as in carcinoma endometrium. Endometrial cancer is the most common of gynecological cancer, so much so that after treatment, after the initial diagnosis, they make a large chunk of survivors who had a gynec malignancy. So what are we going to do for them? So it is a general follow-up of this patient's post-treatment. All of us who are dealing with C endometrium will know about this. But apart from the regular treatment, we'll also have to address this hypertension, metabolic syndrome, diabetes, and obesity, which were the very reasons why she ended up in C endometrium. Without addressing this, there's no point in talking about hormone therapy or menopausal therapy. Menopausal therapy forms part of this menopausal therapy would be LSM, that is lifestyle modifications, should also be taken very seriously. And if they have had were part of this HNPCC or Lynch, okay, so you'll have to order for a microsatellite sensitivity index in the endometrial cancer tissue so that you can identify a subset of patients who are at risk for colonic cancer so that you can advise them timely colonoscopy or periodic colonoscopy to pick up this colon cancers earlier. So it doesn't stop with one cancer if they are part of the syndromic patients. And disease-specific things also should be addressed in the menopausal age group, like chemotherapy and immunotherapy-induced neuropathy and fatigue. In fact, fatigue has been given taken a large proportion of symptoms told by the patients. Lymphedema of late we are trying to avoid that by going for a sentinel node biopsy instead of a general lymphadenectomy. And they can develop radiation-induced GI toxicity and specific to menopause related. So sexual dysfunction can come either because of treatment, mostly because of treatment, because except stage 1A, grade 1, where most of them, receive radiotherapy, they go in for a vaginal stenosis and atrophy, so they can have a sexual dysfunction post radiotherapy. And menopausal symptoms, if they are low risk disease, that is stage 1A, grade 1, estrogen replacement therapy can safely be given as a first line therapy. which may decrease the risk of long-term health consequences. But when it comes to intermediate risk or high-risk disease, better you consider non-hormonal interventions. And HRT should be avoided in uterine sarcomas, particularly low-grade endometrial stromal sarcoma. Now, when it comes to carcinoma ovary, generally speaking, they are CA ovary is disease of the 60s, where our role is very minimal, and they are mostly aged population. But think of a younger patient who had a bilateral oophorectomy for ovarian cancer. These patients should be given the option of having a HRT till they reach the natural age of menopause, and 40% of the patients, as I told you earlier, are diagnosed at an advanced stage. We don't have any say, even they are younger, because of the advanced stage, we are forced to remove both the ovaries and do an entire staging laparotomy. So, what is the goal of follow-up post-treatment in this women with carcinoma ovary? We'll have to look out for risk of recurrence, and role of CA-125 surveillance and circulating tumor DNA is doubtful. And of course, we don't go in for regular routine imaging. And if they are BRCA mutation carriers, please look out for breast cancer risk as well, management as well. And the long-term physical effects because of the therapy can be neurotoxicity, cognitive dysfunction, fatigue, GI toxicity, and surgical and medical complications, depression, anxiety. Anxiety is because of fear of recurrence and preoccupation with cancer antigen values, especially because most of these women have this CA-125 monitored on a routine basis, so they get the fear every time they get the lab report in them. They really don't sleep the previous day till you assure them the next day. And guilt, why would I come earlier? Familial guilt, there was a strong family history, could I have had a oophorectomy earlier, survivor guilt. My other colleagues who were inducted into the program, she died much earlier, would I be surviving later? I mean, surviving at least till next 2 years. All this guilt comes in. Poor body image because of the surgery, because of the most of the surgery done on them is a midline staging laparotomy, which leaves a poor body image. And what are the typical menopause-related issues in there? Loss of fertility in some epithelial ovarian cancer survivors. Of course, they can easily be managed with the current advances in the ART. And sexual dysfunction is mainly because of chemotherapy or radiotherapy. Chemotherapy. And HRT is not contraindicated in epithelial ovarian cancer, regardless of stages, except in very low-grade serous carcinoma. And we do not know what is the role of HRT in non-epithelial tumors. And adult granular cell tumors are considered another histological type of for which caution should be exercised because they are hormone secreting tumors. We do not know whether giving HRT in the form of estrogen replacement therapy post treatment, whether it would kind of reactivate the dormant cells. And for GASM, visual estrogen therapy has come handy. And those who prefer to avoid hormones at any cost, you can manage them expectantly or with non-hormonal therapy listed by Sunita madam. And ovarian cancer, this is one interesting thing I picked up while going through the literature. Ovarian cancer as such is at a high risk for thrombosis, so you should exercise high caution when you are considering initiation of HRT, which will add to the thrombosis risk. And even without evidence of pulmonary embolism or deep vein thrombosis, you better choose a transdermal estrogen, which has got a lower risk of thrombosis, especially when you're combining them with the immune modulators like bevacizumab. Of course, your angiogenesis inhibitors like PARP inhibitors do not increase the risk of thrombosis in general. Although less is known about the safety of concurrent use of HRT and this molecular targeted therapies, HRT is often initiated during maintenance therapy in clinical practice, since maintenance therapy may last for years after chemotherapy, and you choose wisely. Okay, so be conscious of the fact that ovarian cancer itself could have produced a baseline thrombosis on which you're going to add fuel to the fire. So cancer cervix in general, cancer cervix treatment frequently leads to iatrogenic menopause unless they are in stage 1A, where you can consider 1A1, where you can consider a trachelectomy or a therapeutic cone. Okay, otherwise most of them, the primary treatment is vadim cystectomy and without oophorectomy. But after hysterectomy, by about 3 to 4 years, you lose the ovaries lose the power of functioning. They're going for a natural atrophy and they regress. And otherwise, if you are choosing radiotherapy as a first line for some of the patients, either early cancers or late cancers, they can result in premature ovarian insufficiency. So, consequently, a number of patients with cervical cancer may require HRT, but you don't have much contraindications to the use of HRT in this cancer cervix. For survivors in high risk disease, like advanced disease treated with primary chemo, radiation, or surgery plus adjuvant therapy, clinical evaluations can be performed every 3 months. Just a general guideline. And for low risk disease, it is every 6 months for the first 2 years, then annually. Okay, the role of imaging is limited. It's only by clinically that you survive this, go for surveillance of these patients. And what are the disease specific issues? Like in all cancers, you can have fatigue, you can have psychosocial issues, especially they are from unemployed, low socioeconomic status, or low education levels, medical comorbidities, or they are more than 50 years, or lack of social support. Sometimes they have a combination of all these factors which can go in for a lot of psychosocial issues, fear of recurrence, body image issues, secondary malignancies. You must understand you have treated a HPV related cancer in the cervix. The same HPV can cause cancer in the oropharyngeal area or in the anal area. That also should be kept in your mind. So you'll have to, when you're going for a surveillance, you'll have to, scan for this, screen for this areas also, ANS and oropharyngeal areas also for development of secondary malignancies. And uterine sarcomas can arise in the radiated field after definitive treatment for cervical cancer. If you have chosen radiotherapy as a first line of treatment, these sarcomas generally occur more than 10 years. They're very rare, but nevertheless, a patient who develops a uterine sarcoma, you should keep this rare possibilities. What are the treatment specific issues? Sequelae specific to radical therapy or sequelae associated chemoradiotherapy. So, higher perceived stress, depression, anxiety, more frequent gynec problems, worse quality of life is expected. So, HRT is not contraindicated neither squamous cell carcinoma or adenocarcinoma, but where patients had adenocarcinoma in 10 to 20% of the patients, and they had treated with the radiotherapy where there is a intact uterus, you better treat them like a endometrium, and you combine progesterone with the estrogen, like an endometrial cancer survivor. And we do not know what is the role of HRT in rare histology like neuroendocrine carcinoma of the cervix. So what the lessons we learned out of all this? HRT's advantages in certain cancers. It is neutral, like BRCA1 and 2 mutation carriers without any cancers. Endometrial cancer type 2. The logic behind this is endometrial cancer type 2 is a non-estrogen dependent. So you can give estrogen, but again, it's only a logic. We do not have substantial evidence to prove. Uterine carcinosarcoma, adenosarcoma, certain types of ovarian cancer, where we have a neutral attitude towards them. It's certainly contraindicated for various reasons in leiomyosarcoma, certain types of ovarian cancers, like I told you, in granulocyte tumors, brain tumors, advanced metastatic malignant melanoma, lung cancer, gastric cancer, and bladder cancer. It is contraindicated in certain breast cancers, like positive cancer, receptor positive cancers, endometrial stromal sarcoma, meningioma, glioma, hormone receptor positive gastric and bladder cancer. So what are the future directions? Madam already hinted, Sunita Madam, safety of low-dose HRT regimens, novel delivery system like intravaginal rings and microdose transdermal formulations, advances in precision medicine where you can use pharmacogenomic profiling and biomarker market guided therapy, and you can identify patients. The system should identify, help us identify patients who may metabolize hormones differently or are varying levels of receptor sensitivity, thus enabling more tailored and safer use of HRT. That is going to be the future for us. Maybe 10 years from now, we may not be talking like this, we may talk in a different context. And you need to have a long-term prospective studies in cancer survivors. So far, I could get only very limited literature, particularly those diagnosed at a very young age who may face decades of hormone deficiency and unique survivorship challenges. And we have to include diverse patient population in HRT research, including transgender individuals who may require lifelong gender-affirming hormone therapy following a cancer diagnosis. So these are the FAQs with which I like to conclude my talk. What is hormone replacement therapy in cancer survivors? HRT restores hormones lost due to cancer treatment, aiming to relieve menopause or hypogonadism symptoms. What are safe alternatives to HRT for cancer survivors? SSRIs, SNRIs, gabapentin, methyl moisturizers, and bisphosphonates. What is the risk of HRT after cancer? It can increase the risk of cancer recurrence, cardiovascular event, thrombosis, and neonatal hypertension. And I thank CMS and Premlata Madam for giving me this opportunity to be with you all this evening. Thank you.
Thank you, ma'am. That is very elaborate. If we have any questions in the... I don't think we have any questions. We'll move on to the next talk. So I take this opportunity to invite Dr. Nithya Ramachandran, the founder and medical director of Eye Care Multi-Speciality Clinic. And she's got special interest in emergency obstetric care and life support, menopausal health, high-risk obstetrics, and mental health. Dr. Nithya will be presenting a capsule on non-hormonal breakthrough like fezolinetant. So we welcome you, Dr. Nithya, to
Thank you.
please go ahead. Yeah.
Hi, good evening, everyone. Thank you, Chennai Menopause Society, for this opportunity. I'll just start sharing my screen. Just a minute. Yeah. So after that extensive talk by Dhanlakshmi ma'am, we'll go ahead with a small capsule on fezolinetant. Fezolinetant is a non-hormonal, it's really a breakthrough for the non-hormonal preparations, which is useful for menopausal women. Now here we are going to see how it can be used in cancer survivors. Just a minute. Yeah. So vasomotor symptoms are common adverse reactions to endocrine therapy. These symptoms are associated with impaired quality of life. VMS associated with endocrine therapy can be more severe than those associated with natural menopause, particularly in younger women who have often received concomitant GnRH analogs. Now, what happens is once they start receiving these adverse reactions, they might be non-adherent to the endocrine therapy that is being provided. Probably that is why we need a non-hormonal preparation for VMS, which would be safer for them. Hormone therapy, as Dhanamam told, it is gold standard for treatment of VMS, and we can use maybe low dose also. But this approach is generally contraindicated in patients with hormone-sensitive cancers. Now, we have a growing evidence to support the utilization of non-hormone treatment in cancer patients with VMS. I'm not able to change my screen.
Go to non-slideshow and then go to the next slide.
I'm on slideshow, ma'am.
Slideshow and
எடுத்துட்டுமா?
then you'll be able to move.
Okay. Okay, one minute. Give me 1 minute. Is it visible?
No.
No. Okay. Yes, now?
Now, yes.
Yeah, okay. So here we have a drug fezolinetant. It is a new hormonal treatment. That is, it is a new non-hormonal treatment. It is an NK3 receptor antagonist. It is showing a promise for cancer survivors experiencing moderate to severe vasomotor symptoms. And it targets the brain temperature control center without affecting hormones, offering a valuable alternative to traditional treatments. Now, before we go into the drug per se, let us see how it acts. That is, it acts via the NK3 receptors, which are G protein coupled receptors. So they bind, that is, these receptors are activated by neurokinin B. which is found in these NK3 receptors are found in the hypothalamus, especially in the median preoptic area, which is involved in thermoregulation. Now, this area, along with the kisspeptin and dynorphins, it also controls our sleep center. Probably that is why fezolinetant is helpful in sleep control also. Now, these NKB play a role in thermoregulation and also in reproductive hormone regulation. Now, what happens after menopause is the estrogen level, when it drops, it causes increased activity of NKB and NK3 receptors. So there is a thermoregulatory dysfunction, sudden heat loss, and vasomotor symptoms like hot flushes occur. Now, in patients who are having breast cancer for which we have given an endocrine therapy, for these patients, these effects will be a little faster and it occurs in younger age group. So because of this, the effects that the symptoms which they perceive may be slightly more, and a drug like fezolinetant blocks the NK3 receptor pathway, which interrupts and it restores the temperature balance in these patients. And it is one of the first approved non-hormonal therapy specifically targeting moderate to severe vasomotor symptoms of menopause, such as hot flashes and night sweats. Traditional management of hormone replacement therapy, we are unable to use it in patients with breast cancer, thrombosis, stroke, and cardiovascular events. So in such patients, we can give fezolinetant. So it is one of the first line management. And the advantage of fezolinetant is in patients with who are experiencing moderate to severe vasomotor symptoms and in whom we are not able to give SSRIs, SNRIs, or gabapentin due to various their side effect profile, for them, fezolinetant can be given. Dr. Sunita ma'am has spoken extensively about the SSRIs, gabapentin, and oxybutynin. But just to show, throw light upon why they are not used or why they are specifically used is, suppose if a patient has VMS with anxiety depression, we can give SSRIs and SNRIs. Now, if she has night sweats and poor sleep, you will be able to give gabapentin or pregabalin. And oxybutynin is preferred when she is having with VMS with urinary urgency. Now, when these drugs are not we are able to give because of their side effects, then we prefer clonidine. Now, the side effect profile of these drugs are there can be sexual dysfunction, sedation, anticholinergic side effects with oxybutynin, and with clonidine, you can experience fatigue and hypotension. But when you consider a drug like fezolinetant, an NK3 receptor antagonist, as it acts specifically on the temperature regulation center, you don't experience any of these side effects. But a strict LFT monitoring is definitely required. Now, do we have evidence? There are trials like a Skylight trial, which is available and which proves that it is used in menopausal patients without cancers. But in cancer survivors, we have trials which are ongoing. You have Vent trial and Flash breast trial, which are in phase 2. That is, in these patients, fezolinetant for VMS in women with breast cancer or endocrine therapy, you are testing it with placebo also. For example, in this Highlight 1 trial, which is phase 3, it's a confirmatory trial of fezolinetant, 45 milligram is given for moderate to severe VMS in women with hormone receptor positive breast cancer on adjuvant endocrine therapy. So what do we have evidence to tell that it can be given? Direct evidence is only emerging. So at time being, there is a hold on it. But in non-cancer patient with menopausal trials, fezolinetant reduces vasomotor symptoms and it improves the patient-reported outcomes. So that is why these trials have been extrapolated to the endocrine therapy survivorship setting also. Side effects. Regarding side effects of fezolinetant, the common side effects that the patient experience are headache, fatigue, abdominal pain. There can be diarrhea and elevated liver enzymes. These elevated liver enzymes are concerning. So you always take a baseline LFT when we are prescribing the drug. Then we go on to monthly testing for the first 3 months. And then it is in the 6th month. And then in the 9th month, we test the patient. Hypersensitivity reactions are rare. And there is no significant risk of breast cancer or cardiovascular issues, which has been observed so far. The advantage is non-hormonal alternative for HRT, definitely, and it is safe for women with history of breast cancer and thromboembolism. Rapid onset of symptom relief. Now, regarding rapid onset, even drugs like SSRIs, SNRIs are rapid in onset. It will act within 1 to 2 weeks. Similarly, even this drug has their action profile is around effect will be seen in about 1 to 2 weeks, but about 4 weeks, the patient's symptom drastically starts reducing. And it does not stimulate the rest of the uterine tissue, which is definitely an advantage, and it improves the quality of life and sleep. And it is seen that it is well tolerated in clinical trials, and we have emerging evidence regarding regarding its use in cancer survivors. So the take-home message is fezolinetant offers a groundbreaking non-hormonal treatment for menopausal vasomotor symptoms. We know that it acts on neurokinin B and NK3 receptor pathway, and it is an excellent option for women who are not suitable for hormone therapy. Now, early data show good efficacy and tolerability. It represents a new era of menopause care, patient-specific, and it is science-driven, evidence-proved, and it is safe. Now, to conclude, it is a promising non-hormonal option for women in whom systemic hormone therapy is avoided, especially in cancer survivors, provided we are able to monitor the liver function test and drug interactions. Now, regarding drug interactions, these patients cannot be, for example, you're starting the patient on ciprofloxacin, then you'll not be able to give this drug probably because of enzyme-inducing activity. Now, the drug, is it available in India? The drug is available in the name of Vioza, which is a 45 milligram tablet, and it is given once a day. How long we can give the tablet is, the medication trial is up to 52 weeks. So probably till that time, we'll be able to give the medication, provided we are able to follow up the patient. Now, the drug is approved in Western countries, US and Europe, it's approved. But in India, DCGI is not yet, we've not got the approval, but the drug is being imported and it is being given. Now, has the drug been approved in cancer survivors? It is not. So far, even in US and abroad, it has not been given because we do not have the evidence. And in India also, we are not giving the drug for this. Thank you, ma'am.
Thank you, Dr. Nitya. That was a clear, lucid description and a very insightful presentation for that new molecule which is available for practice. I don't think we have any questions. Any questions from the audience? Okay. If there are no questions, we'll move on to the next section. I call upon Dr. Rajshri to speak on lifestyle interventions in oncology clinics. So she is a consultant and lifestyle medicine specialist at RK Specialty Hospital in Crumpet, with special interest in women's health and wellness and preventive women's health. She's been a contributor to the Management of Labor, the 3rd edition book, and she's an active member in many of our societies. We welcome you, Dr. Rajshri, for your presentation.
Thank you, madam, for the kind words. I'll just share the screen. Moving towards this side. Yeah. Is it okay to put it on slide? It's not in slideshow. Is it audible?
Yes, ma'am. Now it's in slideshow.
Good evening. Good evening to all. Lifestyle interventions we know are foundational to holistic oncology care, and it's equally vital alongside medical and surgical treatments. Why? Because WHO says that 30 to 50% of cancers are preventable through lifestyle changes. It is preventable through lifestyle changes. And once, yes, when there is cancer, lifestyle interventions improves the survival, reduces the recurrence, improves the quality of life, but also increases the tolerance to therapy. So we have the core pillars which we use for the interventions. That will be the nutrition, physical activity, the stress management, sleep optimization, social connection, and tobacco and alcohol. I would say avoidance and not reduction. Here, the most important will be regarding the gynae cancers will be the nutrition, physical activity, and tobacco, and we will stress more on tobacco and alcohol avoidance. So first, what are the nutritional recommendations? This is a recommendation. Increase the intake of plant proteins rather than animal proteins. Increase the fiber in your diet to at least 30 to 35 grams per day. The fiber comes from whole grains, legumes, as well as whole fruits and vegetables. Increase your antioxidant rich foods, that are vegetables and fruits, which will contain a lot of antioxidants and the polyphenols like resveratrol, lycopene, carotenoids, all of them will help. And reduce the intake of pro-inflammatory foods, that is saturated fat, processed sugars, processed meat, red meat, and highly processed food. And how would you translate it into a practical dietary advice? The recommendation would be to have a plant-centric, predominantly plant-centric whole food, which is anti-inflammatory. So if you take a plate, half plate would be non-starchy vegetables. So when we give advice, we say include 5 servings each of vegetables and fruit per day. A serving means a handful, or it could be equivalent to somewhere around 180 grams. And quarter of your plate should be whole grains, which would be brown rice, whole wheat, millets, quinoa, oats, we know. And quarter of the plate should be plant proteins like legumes, pulses, and water should be the ideal beverage and the only beverage. Healthy fats can be included. We know that saturated fats, which are avoid saturated fats and trans fats. Keep oil and added fats to the minimum. Okay, oils, although water-based cooking can be done, and avoid processed food and added sugars. We know that these are very important dietary advice. So we stick on to the positive things first, include this, include this, include this, and come to the negative of avoid this later in our prescription. So what is the purpose of this whole food? We mean whole wheat, whole grains, whole vegetable, fruit. When you take it as a whole food, you take it as brown rice rather than white rice, it has got enough of fiber. So the fiber-rich plant predominant eating, the carbohydrate, the fiber is accessible to the microbiota. So when you microbe, which is present in the gut. So we have 2 types of fibers, the soluble and the insoluble fibers, which are present in the food we take. The soluble fibers will delay the absorption of the carbs and thereby reduce the glycemic index and improve the insulin sensitivity or reduce the insulin resistance. Whereas when you come to the insoluble fibers, these are digested by the gut microbe. The more the diverse the microbe is, the more healthy it is, and it strengthens, digests and prepares a layer which strengthens the gut mucosal barrier, and also it synthesizes beneficial short fatty acid chains like butyrate. So the whole plant-centric food, what do? One, they feed the microbes. They're highly nutrient density. That is, the calorie is less, calorie, the nutrient is high. It is sustainable and it is satiating. So you can have legumes, you can have whole grains, you can have vegetables, fruits, yes. If fruits are not economically, you are not able to give it, then you can reduce the number of fruits probably to 3 servings, but the vegetables 3 servings, vegetables 5 servings can be included. So what happens when you increase the animal protein or when you take unprocessed food? When the source is from there is an increase in amount of carnitine and choline, and there is lack of fibers. Animal proteins do not contain any fiber. Animal food lacks the fibers. So what the gut microbes does is it converts these compounds into trimethylamine, and the liver oxidizes to trimethylamine nitrile oxide, which is a potential marker for atherosclerosis, we know, cardiovascular disease, also kidney diseases and cancer. So this leads to pro-inflammatory status, pro-carcinogenic status, and leads to the development of cancer. So this is where what we intake is very important. A lot of nutritional evidences come from the observational studies and meta-analysis, because randomized control trials are difficult. The SOUL trial is a women's health initiative trial which found a reduction in epithelial ovarian cancer risk using a low-fat diet. Next, coming to physical activity recommendations, 150 to 300 minutes of moderate or 70 to 150 minutes of vigorous activity per week is recommended. Getting to or exceeding the 300 minutes in a week is ideal. Incorporate strength training gradually and limit the sedentary behavior, which is very important. So general considerations would be the exercise prescription needs to be tailored to the individual's energy. That is, what level, what part of the treatment she's undergoing, what is the stage, and what is the energy level. And it also depends on the treatment side effects. Depending on chemotherapy, there's a lot of fatigue if they're not able to eat food. So depending treatment side effects, it needs to be tailored. The focus should be on improving fitness, reducing fatigue, and also matching symptoms like pelvic pain. And the approach has to be individualized. Start small, 10 minutes of walking, 10 minutes is enough. Take 2 portions of vegetable, 2 servings of vegetable per day, and listen to the body. Ask the patient to listen to her body. The day she is able to put in 20, yes, it's fine. If not, let her restrict to 10. And the program that we give, the exercise prescription, is based on the FIT principle. That is the frequency, intensity, the time, and the type of activity. Basically, avoid inactivity, that is the sedentary time and screen time. We should tell them to cut on it. Yes, whether you're being active or not, avoid the sedentary time. Get up and walk in between and reduce the screen time. So the key components will be aerobic, resistance training, flexibility and balance, and pelvic floor exercises particularly. So the aerobic training, the goal will be 150 minutes per week. Moderate, which will be brisk walking or cycling, or vigorous would be jogging. Frequency would be start with 3 to 5 days a week, or most days if possible. Intensity is moderate, which means while you're walking, you can talk, but you're slightly breathless. You cannot sing, which means it is mild. And if you cannot talk sentences, then it becomes a vigorous activity. And the type would be walking, swimming, cycling, dancing, water aerobics. I've not included the time because you start with 10 minutes or 5 minutes and gradually increase. Even 10 minutes of working at a time definitely helps. Resistance training, the frequency would be 2 to 3 sessions per week on non-consecutive days. Don't do it on the every other day. Just leave a gap of 1 day at least between for the muscles to recover. The intensity can be moderate to vigorous, and the type would be either free weights, it could be machines, it could be resistant bands or body weight exercises. The timing again depends. Start with 20 minutes, depending on how many days you're doing. Gradually extend the session based on how fatigued the patient or the woman is. Flexibility and balance, you need to include gentle stretching, yoga or tai chi to mobilize to maintain the mobility and reduce tension. Pelvic floor exercises are crucial for restoring the core pelvic floor function post-treatment. And also if they have lymphedema of the hand, particular exercises for the upper limbs will be helpful. So how do physical activity work? You know, it regulates hormones, reduces inflammation, boosts the immune function, manages the body fat, improves the metabolic pathway, and also affects the functions of the gut microbiota. Overall, it disrupts the cancer cell growth signals and strengthens the defense. And the more intense the activity, the greater are the benefit. But look at individualize the prescription. So the benefits are from prevention to increased tolerability to chemotherapy, increased efficacy of chemotherapy, lowered risk of recurrence. It improves the mood, right? And therefore, they are more easily accessible. They are able to take the therapy on and work, lowered risk of recurrence, promotion of post-treatment recovery of physical function and overall well-being. That's what endorphins which are released creates a well-being, and it prevents concurrent development of other medical conditions, development of diabetes, develop of heart disease, which is going to interfere with your treatment. That is also taken care of with physical activity. Next, the tobacco and alcohol I have taken because we know that tobacco products, they get activated in the cervical mucosa and they cause local suppression of immunity and therefore persistence of infections, high HPV infections, that leads on to progression to cancer. So it is actually the immune suppression which is caused by the carcinogens which are metabolized and the active ingredients is present in the cervix. So a progression, if you look at the smoker and a non-smoker, LSIL can regress in a non-smoker, but it does not and remains same and progresses in a smoker. So these are the 5 A's model. Whenever you see somebody, alcohol, we know that it increases the recurrence. It is directly proportional to the amount of alcohol taken. The more it's taken, and there is no amount that can be that is safe. The normal quantity is only for the cardiovascular health. For the carcinoma, any amount is directly proportional to the recurrence and the growth of the carcinoma. So just whomever you see, when you meet, ask everybody, do you smoke? Immediately advise quitting, tell them. And then once you advise, you assess the readiness. Yes, whether they will listen to you, what will they do? And then you assist them to help quitting either by CBT, cognitive behavioral therapy, or by pharmacotherapy. And then also give a date and arrange for follow-up. It is very important that we take this tobacco and alcohol seriously. The other pillars, stress, if one pillar is affected, the other pillars are going to get affected. Non-epinephrine and cortisol will promote angiogenesis, suppress the immune system, ability to destroy cancer, and inhibit apoptosis. So when you have stress, you go in for unhealthy coping mechanism, alcohol, smoking, lack of sleep, and then obesity, no exercise, unhealthy or food. And the treatment would be again yoga, mindfulness, cognitive behavioral therapy, and support groups here will definitely help. Being socially connected and having support groups always helps in resilience and longevity. And it has been proved in 75-year-old Harvard study how the resilience, how social connections helps with resilience. And sleep, again, poor sleep leads to poor quality of life. We have to look at the hygiene essentials, the time to bed, the time up, whether how the noise in the room, whether what happens to the sound, the light, and then consumption of dinner, which will be a complex carbohydrate, at least 2-3 hours before, and then consumption of coffee, alcohol, and when. So these are the sleep essentials which you have to look to. And then if they are not effective, cognitive behavioral therapy for insomnia is very effective. So looking at the quick clinical flow, screen for all lifestyle factors. That is the 6 pillars we'll have to screen for quickly. Look at what is it that they are lacking. Are they snacking on processed food? Are they taking vegetables? Are they taking fruits? Are they walking? Include everything. Are they stressed out in their job? So quickly assess each one of that and then take only 1 or 2 priority behaviors. Even if you have to take a meal, just add 2 servings of vegetables today. That's it. Add it. Come back. Follow up after a week. Start with 10 minutes of walking, or don't sit for a long time. If you feel you're sitting for 3 hours, just start. Increase. Take 10 minutes walk in between. Start there and gradually progress. Give specific instructions. Say non-starchy vegetables. Take 1 handful, which will be 1 serving. If you can do 2, if you can 3 in your diet, if you can include fruit. So the instructions have to be specific about, and also when you take your exercise, how long, whether it is moderate, what is the intensity, what is the type of exercise you will want to do, and of course include the caregivers, because it is a time when you can educate them also. It is a teachable moment where you can educate the entire family. Please include the caregivers also. And you should focus on survivorship focus, that is preventing recurrence, managing long-term effects, that is they'll have peripheral neuropathy, they may have osteoporosis. We have to look at all those and manage. We'll have to rebuild function, like I said, pelvic floor exercises. And if they have edema, then you'll have to look at upper arm exercises, and also, yes, prevention of non-communicable diseases. So there are implementation challenges in a clinic, both with the physician part as well as the patient part. Time constraints. Whenever you say, no, I am watching that serial today, I don't have this time for that. And when we come to us, yes, we have to devote a lot of time during our consultation, which needs to be, we have to keep separate time for that. The fatigue burden, as all of them has discussed, Madam has discussed, Sunita Madam has discussed, the fatigue is a lot in these cancers. And yes, we have to consider and slowly include the in in small increments we'll have to give. There are cultural barriers. People believe that, yes, it is their destiny. They do not come out. They do not want to walk. They think of cancer as a taboo, and limited staff. We don't have any staff to handle the load. So what will be the practical solution? Will be having a patient-centric counseling sheet. So you will have the assessment, you will have the goal set for them, ask them to, the goal will be a SMART goal, and then that is specific, measurable, achievable, realistic, and time bound. And it will be an action plan which will be written by the patient. Yes, I will do this, 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 this. And then let them go through it. And if they come across any barriers, you need to solve the problems during the follow-up. So a counseling sheet must contain all of these. We can take group classes on educating, and you can take physio also on site. And digital follow-up, of course, is very, very important. That follow-up is very much necessary. So the take-home messages will be lifestyle interventions definitely improve outcomes. Small, sustainable changes. Yes, sustainable, start small, personalize the prescription, and yes, it needs multidisciplinary approach. Thank you.
Thank you, Dr. Rajshri.
Thank you.
I think you've summed up most of it very well. Over to you, Dr. Nivedita.
Thank you, ma'am. Now that we have finished the scientific session, now it's the quiz time. And the link has been there in the chat box. And I request all the delegates to participate the quiz. And the link will be open for the next 24 hours. Now that we have finished the elaborate scientific session, now it's time for vote of thanks. And I'm happy to thank our chief guest and the guest of honor on behalf of the Chennai Menopause Society, Dr. Meeta Singh and Dr. Seema Sharma, to be with us, for having been with us through this program. And I also extend my heartfelt thanks to the chairpersons, Dr. Meera Raghavan and Dr. Nandita Thakkar, for carrying out the session. And not but the least, my heartfelt thanks to all the faculty who made a very elaborate presentation, Dr. Sunita Samal, Dr. Dhanalakshmi, Dr. Nitya, and Dr. Rajeshri, for their elaborate presentations on a very important topic of the day. And I also thank our President, Dr. Premlata ma'am, and the Secretary, Dr. Deepa, for putting the program together and running it through successfully. Thank you, one and all. And last but not the least, I also extend my heartfelt thanks to Shield Connect, Shahita.
Yeah.
Is it okay? Yeah. Thank you. Thank you, one and all.
Thank you. Bye.
Thank you, Ramani.
Thank
It was
you.
a nice program.
Thank you,
Thank you,
ma'am.
Premlata ma'am.
Bye-bye.